Good evening, everyone. How are you all? All right. So can any of you just unmute yourself and say hello? I just want to see that if I can hear you fine.
Hello,
Hi,
sir.
hi, doctor.
Oh, all right. Great.
Hello.
Okay. Thanks, everyone.
Hi.
Okay. All right. Thanks all. So let's start our tonight's session. I'm just going to share my screen now. So welcome to First Aid AMC Clinical free 2-week sessions again. So this is your few left classes. So we have 2 more sessions with you for this 2 weeks free session. And we just have cardiology class 2 and 3, right? So this is going to be your last 2 cardiac session with me as part of the free session. And after that, we are going to start the course in full rhythm. So we have already planned your course. The orientation class is going to be on 23rd of this month. So we are going to do the orientation for this new clinical course on 23rd, which is going to be Friday next week. Okay. I hope I know that most of you are already the students who has joined the course, but if any of you who haven't joined the course yet, this is the time to get enrolled so that you can start with us with full rhythm. And also you should definitely join the orientation class where we are going to show you how to start your preparation, what to do. If you have any questions, you get to ask any kind of questions that you are worried about. So it's going to be a very, very important sessions for the course student. Okay. How was the last night session with Dr. Rabiha? Great. Yeah, she's really great. So we really like how she does all the role play things. So you're in very good hand. And also, I was happy to see that many of you were doing role play, and that's really good because initially we find it difficult to get students to do role play with us, but you guys were doing really great. So it's really fun, really perfect. So, and also you can find out that if you are willing to do a role play, then you get to do a lot of role play with us. It's all about like we see a lot like few students do a lot of role play and few don't. So we always encourage you to come and do role play. Make sure that you get that confidence so that in exam you feel really confident and you don't get that nervous that even if you know something, you will do wrong in exam. So the confidence grow gradually, especially I say that if you can do role play in front of so many people, then in exam it's going to be much easier than what you're doing now. Okay? Yes, so Tarindo, the final date to settle the second installment is the 8 weeks from the start of our course. Cardiology class 1 has been shared in YouTube. And Augustine, if you are already enrolled student, then we have already added that into our portal. So did you guys go through the last cluster, which was the chest pain cluster? So similarly, our cardiology class 2 is syncope cluster. Syncope means loss of consciousness, and loss of consciousness or syncope is a very, very high yielding topic for exam. A lot of questions come from here. You'll see today. So when we get a patient with syncope or loss of consciousness, in our mind, we think it could be cardiovascular, could be central nervous system, could be a lot of miscellaneous. CVS is the most important one. So it could be arrhythmia, any kind of arrhythmia, aortic stenosis, HCM, myocardial infarction, or prolonged QT syndrome. As part of CNS, we always rule this out: TIA or stroke, head injury, infection, epilepsy. As part of others, that's where a lot of questions come in exam. Vasovagal is important, postural hypotension, hypoglycemic attack, anemia, sometimes medication induced, like a patient who is on multiple volume depleting medication, ACE inhibitor, diuretics, the alpha blocker. So they can get really low blood pressure because they are in a lot of medications which can cause hypotension. Alcohol hangover. Now we got one question which was alcohol hangover in exam. Reproductive female age. So any reproductive age group patient, especially like female patient, which if they come to us with syncope, do not forget to rule out pregnancy, ectopic pregnancy, or menorrhagia. That means heavy bleeding causing iron deficiency anemia, and they're losing consciousness. And always rule out anything psychological. So could be a stress induced or psychogenic. Okay. So these are our main differential diagnoses for syncope. Now, the exam questions from here is aortic stenosis, prolonged QT, doesn't come under CNS, vasovagal, postural is very important, hypoglycemia. We discuss hypoglycemia in a separate cluster, but it comes in exam. Anemia, alcohol hangover, reproductive, not that much, not under syncope cluster, and psychological, that it can come anytime. Okay, so these are usually the cases. So let's start with the history for syncope. So patient with syncope, they usually come to you within a day or 2 days after losing consciousness. So they are quite acute presentation. So your history should start in the same way. So you'll first greet and introduce yourself with the patient. So you'll say, "Hi, John." So let's say we have got a patient, John, who lost his consciousness yesterday. "Hi, John. This is Dr. Arshan. I'm one of the GP in this medical center, or I'm one of the GP in this clinic. Very nice to meet you. John, I get to know from the note that you had an incident where you lost your consciousness yesterday. I'm so sorry to hear that. How are you feeling now?" Patient will say, I'm okay now, doctor." You'll say, "That's great. John, I'm going to ask you a few questions about what happened, but before I do that, I just want to make sure you are vitally stable. So please excuse me for a moment. I'll come back." You turn towards the examiner and ask the examiner, "Dear examiner, is my patient vitally stable for further history?" Examiner can say, "Go ahead, stick to your task," or "What do you want to know?" If examiner say, "What do you want to know?" then definitely you will ask, "I would like to know the blood pressure with both sitting and standing, because postural hypotension is one of your differential. Also pulse with rate and rhythm, because arrhythmia is one of your differential. And others not that important, but at least blood pressure and pulse you should ask. You can definitely ask the rest of it, like respiratory rate, temperature, and saturation. Once you have done that, you'll come back. So thank the examiner, "Thank you, examiner." Then you turn towards the patient and say, "Thanks, John, for waiting. John, now would you please tell me a little bit more about what exactly happened yesterday?" So we always start with presenting complaints, and our patient's presenting complaint is syncope or loss of consciousness. Definitely, we will not say, John, you had a syncope yesterday. We don't use medical jargon where we can. So when we do a syncope questions, we divide the syncope question into what happened before you lost consciousness, during syncope, and after syncope. So pre-syncope, that's the first question. Can you tell me a little bit more about what exactly happened? So patient will give you some idea like I was climbing mountain, or I was trekking along a mountain and suddenly I lost my consciousness. So if we don't know what patient was doing at that time, if patient did not give that to us when we ask that open-ended question, we will need to ask that what exactly were you doing at that time? So patient can say like, what exactly happened yesterday? So patient says that, well, I was just sitting in my on my sofa, and then suddenly I felt a bit dizzy and I lost my consciousness. So usually you get to know what patient was doing before this happened. So normally you don't need to ask this question, what exactly you were doing at that time. Okay? But we really need to know what patient was doing. If we haven't found it out, then we will ask it. Is it for the first time? Very important to know that if it happened for the first time. Now, patient can say yes, or patient can say no. This is the fourth time. So if patients say multiple times, then we will need to find out the details of all the previous episodes. So let's say patient says, no, I had few other episodes. So you will say how many episodes you had so far, when was the first time you got it, what exactly you were doing at that time, and when was the last time. Okay? When was the last one before this one? So you just get an idea that what patient was doing and what brought it on. So if patient said, no, this is not the first time, definitely we need to go a little bit detail about the past episode. So how many episodes so far? When was the first time it happened? What exactly you were doing at that time? Okay. Could you please tell me the details of the other episodes when it happened? So get a bit of an idea that if you can find out that if there is any particular relationship to something that causes this kind of syncope. If it is first time, then we are good. We move on to the next question. Did you fall suddenly, or did you feel any lightheadedness or dizziness before you fall? Why we ask it? Because we want to know that whether it is a cardiac syncope or it's a vasovagal syncope. Cardiac syncope patient, they will just fall suddenly without any prodromal symptom. But if it is a vasovagal, they will have a bit of a prodromal symptom, which will be lightheadedness, dizziness. They can even have blurry vision, sweating, trembling. So they will know that they are going to fall. Okay? So that's very important to know. And rule out any CNS related symptoms during that time. So any headache, blurring of vision, any weakness, any part of the body. So that's before syncope. Then during syncope, we want to first know that was there anyone else with you? So if there was, because when patient lost their consciousness, they will not know what happened. So it becomes tricky. So that's why we ask that, was there anyone else with you? So did you lose your consciousness? How long you lost your consciousness? Did the witness or did the other person noticed that you were having some jerking movement of your body? Did you wet yourself or pass a stool? Did you bite your tongue? Did you injure your head? Okay, so why we're asking this? So first of all, we really need to know whether it was just a fall, which will be pre-syncope, or was it a case of full syncope, which is loss of consciousness. We also want to rule out epilepsy, that's your differential, so jerking movement wet yourself, pass a stool, bite your tongue, all of them are epilepsy question. And if they suddenly have a fall, they can they can injure their head, which is also important to rule out. Post syncope, after you regained your consciousness, did you feel confused or drowsy? Were you able to stand by yourself or someone helped you? Did you have any weakness or any problem with your vision or speech? So we call it post-ictal confusion. So sometimes what happens that if a patient had a epilepsy, they will feel confused for 30 minutes to 60 minutes. Also, if it is a cardiac syncope, it happens suddenly and patient gets better suddenly. So when they regain their consciousness, there will be no more confusion. So it also helps us to know that it is cardiac. So if patient had a fall suddenly and then also wake up suddenly and after that patient was completely fine, we would think of cardiac related cause. All right. But if it was a bit delayed, like vasovagal also takes a bit time. Neurogenic syncope takes a bit of time to feel better. We are also ruling out any CNS-related differential by asking this stroke question. So weakness, any problem with vision or speech. Okay, so that's our first question. After that, we will go to the differential. So first for cardiovascular, any chest pain, shortness of breath, any racing of the heart. That will cover all the differential diagnoses that can possibly be here. So all of them, MI, aortic stenosis, arrhythmia, all of them, that's the same question. So any chest pain, shortness of breath, any racing of your heart. You can definitely ask any excessive sweating, nausea, or vomiting to rule out any MI-related symptom. For CNS, you asked a lot of questions already, so there is not much to ask anymore. So you ruled out stroke by asking any weakness, any vision or speech problem. Same with the TIA. You ruled out epilepsy. If you did not ask head injury yet, then ask about any head injury. And also rule out any infection, which is epilepsy, which is meningitis. So any fever, rash, neck stiffness. All right. And also headache you can ask, especially for meningitis. So that's CVS and CNS. So not very difficult, right? Now we are going into the miscellaneous causes. So for hypoglycemia, did you skip your meal yesterday? So it depends on when it happened. So if the loss of consciousness happened today, we will just say, did you skip your meal before you went for the trekking? Or before you went for the hiking? So we just ask that question because if patient skipped their meal fully and then went for a heavy exercise, long walk, that can also cause a hypoglycemic attack. So we just ask that question. If we want to go a bit more detail about hypoglycemic symptom, we can always ask that, did you also have shaking, sweating during that time? Did you feel tingling numbness around your mouth? Did you feel very did you feel very hungry? So all of these are hypoglycemic symptoms. So patient will have shaking, trembling, sweaty, tingling numbness around the mouth. They can feel very hungry. So all of this can be hypoglycemic symptom. But we really don't need to ask that much of a question. We would definitely ask if patients say, yes, I skipped my breakfast and then I went for the hike. That's the time we will ask a bit more that, well, when you had that symptom, did you also get very shaky, trembly, sweaty? Did you feel some tingling numbness around your mouth? Did you feel very hungry? All right. And we will also ask that, do you have any history of diabetes or high blood sugar? After that, we go to the vasovagal. Vasovagal, there is not much of a question. Just by the the presentation of the patient, we get an understanding that it could be vasovagal. How? If patient says that I was running marathon today and then suddenly I felt a bit lightheaded and dizzy, and then even if I stopped, but I could not I could not control myself and I had a fall and I lost consciousness. Okay? And you can ask that, was it a very hot sunny day? Okay? So vasovagal is basically patient usually will be standing for a long time or patient will be running heavily under the sun. So something exertional. And they will have this prodromal symptom before this happens, and then they lose consciousness and gradually regain consciousness again. Okay, so what we ask in here for vasovagal that were you standing for a long time before this happened? What were you standing in, or was it a very hot sunny day when this happened? Okay, and also when you ask that question of pre-syncope, that did you get lightheaded dizziness before this happened, that will give you much clue about the vasovagal. Apart from that, nothing to ask. For postural hypotension, do you feel dizzy when you get up from the bed in the morning? We know postural hypotension happens when they change their position. So usually what happens that they lie down and then they sit up and then they stand up, right? That's what we do. So when we change our position, especially from sitting to standing, if we feel dizzy or lightheaded, that's the time we think of postural hypotension. An elderly patient usually get it very common. It's a very common presentation. So we ask this question, do you feel dizzy or lightheaded when you get up from the bed in the morning? Okay, or when you change your position. For anemia, do you feel very tired or fatigued these days? Only one question is enough. If we find something positive here, then we ask that, are you losing blood from somewhere? Do you have healthy, balanced diet? Are you losing weight by any chance? So we just ask questions if we find something positive. But if we don't find something, then we don't ask a lot of questions because we will not have that much time. If it is a female in reproductive age, then we will need to ask about their period, whether they can be pregnant. So ask about that. So you'll just say before you ask this question, so Jenny, I'm just going to ask you about your period. Is that all right with you? So when was your last menstrual period? Patient says 2 weeks ago. And you just say that, is it regular? Yes. And you can say, are you sexually active? Yes, doctor. Are you taking any contraception? Patient says no. Is there any chance that you can be pregnant? So these are our questions for the reproductive age group. So when was your last menstrual period? Is it regular? Are you sexually active? If yes, are you using any contraception? If no, is there any chance that you can be pregnant? Next, ask about any stress. So give a bit of a confidentiality. Say that, John, I'm just going to ask about your home and work situation. Please be aware this is confidential. John, how is your home? Is there any stress there? Any stress at your work? That's all that we need to ask. And then we ask about the past medical history. How is your general health? Any past medical condition such as high blood sugar, high blood pressure, or any heart condition? Do you smoke or drink alcohol? Are you taking any regular medication? That's SADMA. Any family history of heart disease? Any family history of sudden death in young age due to any heart condition? So sudden cardiac death in young age usually suggests HOCM or also suggests a possibility of a prolonged QT syndrome. Clear, everyone? So that's going to be our history for syncope. So we're going to start with the hemodynamic stability. Then we go to the presenting complaint, pre-syncope, syncope, post-syncope question. Then we go to the differential diagnosis, severe CNS. Then all the others, hypoglycemia, vasovagal, postural hypertension, anemia. If it is female in reproductive, then we ask about their period, pill partner, pregnancy, stress, and then finish with past medical, family history, and SADMA. All good, everyone? All right. So now the next thing is physical examination from examiner. So it's going to be exactly the same one that we have done in our chest pain cluster. So for physical examination from examiner, same thing, we start with the general appearance. We'll go to the pickled. For pickled, only thing relevant will be pallor. For cardiovascular, we also ask cyanosis, edema, you can ask that. Vitals and BMI, same in the neck, JVP, carotid bruit. Then the same cardiovascular as we discussed. In here, because CNS is one of your differential diagnosis, you will just say, after the CVS, you will say, I would like to also check the central nervous system. Or you can say, I would also like to examine the full central nervous system exam, including all the cranial nerves. That's all that you need to ask. And then ask for office test. For cardiovascular, office test, BSL and ECG is the most important one. So ask about blood sugar and ECG. Urine dipstick, not needed unless if you're thinking of pregnancy, you can ask for urine pregnancy test. Otherwise, urine dipstick is not that important here. Okay? So I hope you remember how we did the physical exam from examiner last time. If anyone need me to repeat it or you want me to do it, just tell me. I will do that.
Simple question. Can we say the CNS or we can tell him detailed central nervous system?
Say central nervous system. That will be better.
Okay, thank you.
Okay. So if I do the physical exam for this case, it will be, dear examiner, I would like to do physical examination on my patient. On general appearance, is my patient comfortable or in distress? Any pallor, cyanosis, any sign of edema? I would like to know the vitals. So you ask the vitals how we do. Then I would like to check the neck for any raised JVP or carotid bruit. I would like to focus on cardiovascular system, on inspection, any visible cardiac impulse. On, on palpation, I would like to know about the apex beat position, any palpable thrill or parasternal heave. On auscultation, apart from S1, S2, is there any added sound like murmur? Then I would like to do complete central nervous system exam, including all the cranial nerves, please. Examiner, is there any office test available, such as blood sugar level or ECG? That's how you do it, okay? And remember, you'll need to give some time in between for examiner to give the findings to you.
Sir, as in CVS, we explain the details from inspection to auscultation. But in
Yeah.
case of CNS, do we have to do the details examination of CNS, or we only tell the we now I want to know about the details about CNS, including cranial nerve.
You don't need to, because if only you will do the complete CNS, like how we did the CVS, if you find a stroke or any CNS related cause, which is unlikely in a syncope cluster in exam. So if you find like this patient had a stroke or TIA, that's the time we will do full, which is not usually the case in exam. Okay?
Okay, sir.
All right. Moving on to the cases under syncope. So the first one is aortic stenosis. Aortic stenosis is also a handbook case. So if you know that you have a handbook for AMC clinical exam also, where you have 150 question, and those questions are high yield questions. So definitely go through them, read it at least a couple of times. Although it is quite old, but it's still the guideline is same. It means that how the exam occurs is still the same. That means the essence of exam, the main things in exam that they look for, it's been always the same. So sometimes management is a bit tricky. It has changed, but most of the things that comes from handbook, we also discuss this in the course. But still, I want you guys to read it at least few times. Okay. So you are a GP. Your next patient is a 52-year-old male who is consulting about recent loss of consciousness. So we know we're in a GP setting. We know it's a 52-year-old male, and our presenting complaint is syncope, right? So task is history, PFE, investigation, diagnosis with management. So when you ask the history in this case, you will find out that patient will say, I was playing tennis yesterday and suddenly I started to black out. And when you ask about shortness of breath, you will find out patient experiencing this shortness of breath, especially on exertion for the last 2 months. And also during the shortness of breath, patient gets a bit tightness in his chest. The classic triad of aortic stenosis is chest tightness, shortness of breath on exertion, plus syncope. So that's the classic triad. With that, to confirm aortic stenosis, during your physical exam, you need to get a murmur. So that's the time when you do the auscultation and you ask the examiner about any murmur, you'll get that murmur. So what happens in here, sometimes when you say, apart from S1 and S2, is there any other added sound like murmur? Examiners say yes. Now, if you don't ask a little bit more, you will not get the finding. So only knowing that there is a murmur doesn't give you the full diagnosis. You need to know what type of murmur, where is the murmur. So that's important. So sometimes we need to ask a little bit. So we ask examiner, I would like to know the type and position of the murmur. So the type of the murmur is ejection systolic murmur, and the position is aortic area. Sometimes they can also say right second intercostal space. So aortic stenosis murmur is best heard at the right second intercostal space. And also it radiates to the neck. So you need to memorize some of the common murmur, especially mitral stenosis murmur is mid-diastolic murmur. Any mitral murmur is best heard at the apex, which is the left fifth intercostal space. Mitral regurgitation murmur is a pansystolic murmur, and that radiates to axilla. Same, it is best heard at the left fifth intercostal. We know aortic stenosis murmur is an ejection systolic murmur, best heard at the right second intercostal. And then aortic regurgitation murmur is an early diastolic murmur, best heard at the left fourth intercostal space along the sternal border. So these four murmur are commonly asked, and you need to just memorize them. There is no way to remember them or no mnemonic for it. You just memorize. Okay? So it should be in your head all the time because any murmur can come in exam. So MS, MR, AS, and AR, these four murmur you should remember. Okay? So we have got a patient who has ejection systolic murmur in the right second intercostal space radiating to the neck or carotid. That confirms our diagnosis that this is a aortic stenosis. Okay, so with your history and physical examination format, you will get all this information. Then you come to the explanation. So you'll explain to the patient that, John, from history and physical examination, most likely you have a condition called aortic stenosis. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. This is your heart. Your heart has four chambers. These are upper chambers and these are lower chambers. Each of these chambers has a door-like structure. Now, these door-like structures are what we call as valve. In your case, the valve that controls the flow of blood from the heart to the aorta, called aortic valve, has got a bit narrowed. That's why it is harder for the blood to flow from your heart into the rest of the body, especially to your brain. Again, so you draw and you explain. So we have got, so this is your heart. Heart has four chambers. Each of the chambers has a door-like structure called a valve. In your case, the valve that controls the flow of blood from the heart into the aorta, called aortic valve, is got narrowed, making it harder for the blood to flow from your heart into the rest of the body. That's why the blood supply to your brain gets reduced, especially when you exercise, causing the loss of consciousness that you had. When you exercise, the demand of oxygen from the heart gets increased. But this valve is already narrowed, so it cannot supply enough blood and oxygen that you need, causing the chest pain and shortness of breath that you have been experiencing for the last 2 months. Now, that is the best way to explain something. When you explain something, it should indicate why I am getting these symptoms. So you always try to correlate patient's symptom with the explanation of the condition. Because patient needs to know why I'm feeling short of breath, why I get chest pain when I play tennis. And when you can explain that, it makes a lot of sense to them. So always after explanation, ask, are you with me so far? Did you understand? Okay. So then if your task is differential diagnosis, give some differential diagnosis here. Like you can say it could be due to other condition as well. So then you just think of what you have ruled out. So you'll say that it could be some heart rhythm disturbance, but you haven't got any racing of your heart. It could be heart attack, but you haven't got at the moment you haven't got a chest pain, and heart attack usually doesn't come with abnormal heart sound like murmur that you have got. It could be some brain related condition like stroke. You don't have weakness, loss of weakness or any problem with your vision or speech. Could be related to head injury, but you haven't got any. Could be infection in the brain, but it doesn't look like you have got it because you haven't got fever, headache, or neck stiffness. Could be others such as vasovagal, but the presentation that you have got, like the sudden loss of consciousness without any prior symptoms, does not go with vasovagal. Sometimes patients get dizzy or they have a fall when they change their position, which we call postural hypotension. But in your case, you haven't got that. Could be low blood sugar, but there's nothing suggesting that. Could be some medication induced, but you are not currently on any medication which can cause this. See that this should come from your own way of explanation. There is no one good way to do this, but you need to know how to say differential diagnosis like this. It's very, very good. Now, if diagnosis and differential is your last task, then you finish here. But if management is a task, then you will need to go in. So you will say, first of all, I'm going to arrange a ECG here to check for any baseline heart abnormality. And then I'm going to send you for an echocardiogram, which is a scan of your heart, which will confirm the narrowing of the heart valve with its severity. Then I'm going to send a referral to a cardiologist for further assessment and treatment. Treatment depends on the severity of the narrowing and the symptoms of the patient. If the narrowing is not too bad and you don't have severe symptoms, a specialist will just keep an eye on it. You will have regular checkup and heart scan every 1 to 5 years, depending on how narrow the valve is. If the narrowing is severe, now severe narrowing, you don't need to mention it to the patient, but that's what we call severe aortic stenosis. So valve area less than 1 centimeter. If the mean gradient more than 40 on echo, or reduced ejection fraction. So usually if the valve is less than 1 centimeter, then definitely that is severe. And with symptoms like this, patient will need a replacement of the valve. So if the narrowing is severe with your symptom, specialist might recommend replacing the valve either surgically or using a catheter-based approach called TAVI. TAVI is transcatheter aortic valve implantation. Okay. Now, do we need to explain TAVI in detail? Not really. If you even just say that the specialist might recommend replacing the valve surgically or using a catheter-based approach called TAVI, that's enough. Okay, so what happens in TAVI is previously we used to do surgical valve replacement, but nowadays it's a minimal invasive surgery where the cardiologist will use a catheter and that will be entered into the blood vessel into the groin, and then it goes into the heart, and then it just deploy a new valve inside the old one. So if you really need to say, then you can say that in this procedure, a thin flexible tube will be passed through your groin blood vessel into the heart, and then a new artificial valve will be placed inside your aortic valve to restore the proper blood flow. Okay, so very simple. So a thin flexible tube will be passed through your groin blood vessel, then it will go into your heart, and then it will just a new artificial valve will be placed into your aortic valve so that a proper blood flow is restored there. Okay, so you can explain in that way if you have time, but if not, just say surgical or TAVI. Also advise lifestyle modification. So say along with this, so until you wait for the cardiologist to see you, please make sure that you follow healthy lifestyle. If patient is smoking, advise the patient not to smoke. Advise the patient to follow healthy balanced diet. Ask the patient to avoid any strenuous activity for now. So do not go for a long walk, heavy jump, heavy run, or something like that. And then bring back the patient after the echocardiogram to check the report. Okay, and also manage any other cardiovascular risk factor this patient might have. If patient have high blood pressure, you need to give antihypertensive. If high cholesterol, a statin. If the patient is obese, then you might even need to organize a dietitian and an exercise physiologist to be involved so that the patient can lose weight healthy, like in a healthier way. Okay. So these are if we really need to, but the main explanation that you need to do is you do an ECG, do an echocardiogram to confirm the narrowing and its severity, and then send the patient to a cardiologist for further assessment. And then mention that treatment depends on the severity. If it is not that severe, then just conservative approach. If it is very narrowed, then it will be replaced either surgically or a catheter-based approach. All right, clear everyone? Any questions on this? No, they don't give true patient with a murmur in exam. Next question. So now we are moving on to prolonged QT syndrome. Prolonged QT syndrome is also another cause of syncope. It's usually common in young patient to come to you with a syncope like this. 19-year-old girl comes to the ED because she fell unconscious 2 days ago while she was climbing up a mountain. Your task is pretty much same. So positive finding in here was patient was climbing a mountain and had a sudden loss of consciousness. This is the third time and she was doing different things each time. There is no other symptoms of shortness of breath, chest pain, palpitation, but has a history of unknown heart disease in maternal uncle. So that's one of the very important clue to think of prolonged QT syndrome. You can also think of HOCM in this patient given there is a family history, but how we would know? In this case, they will provide a ECG. So sometimes they say that ask investigation from examiner. So that's the third task, ask investigation from examiner. And then examiner, if you say that examiner, I would like to have a ECG for this patient, then examiner will give you the ECG. Now, if the task is just this, investigation from examiner, then you don't need to explain the ECG to the examiner. But sometimes they say, ask investigation from examiner and explain this to the examiner. So if the task is explained to examiner, then you need to remember the format that I have shown you, how to explain ECG to examiner. That's the way you have to do it. In this case, when you come to the physical exam from examiner, there will be no murmur, but they will provide you a ECG where you will get a prolonged QT. You have to find it out. Examiner is not going to give you that. So you have to find out from the ECG. So having a good knowledge on ECG is important. So we know the normal ECG has a P wave, then this QRS, and this T wave. What is QT interval? QT interval is starting of the Q wave and end of T wave. That's what we call QT interval. In a normal patient, QT interval is between 8 to 11 small square. That's the easiest way to find out from the ECG. Okay? Now, sometimes if you are if you are using your brain, sometimes you also find out that when they give you the ECG, just on the top over here, you might see the QTC. So they give you finding that what's the QTC of this patient. So just look at that. A normal QTC for men, if it is more than 440 millisecond, that means that's prolonged QT for men. And if it is more than 460 in women, that's prolonged QTC. So even just by looking at this ECG, sometimes on the top they give, usually like when we do the ECG, these findings come automatically. So if they give you that QTC, you don't need to even read the ECG. You'll get it over there. Sometimes even the heart rate comes automatically in ECG machine. So look for those findings here because sometimes that can save time. But if it is looking like this, blank, there is no other information, then you will have to find it out by yourself. Now, how to check all of this? So we know that this is a syncope patient. For a syncope or palpitation case, we look at the long lead. So long lead is the lead that's at the end. Lead 2, you can see, you can read the full lead here. And the other leads are quite just tiny, right? So up to this. So if you look over here, we always will start with the lead 2, the long lead. So first we check the heart rate. So we can, or even before that, we check if it is regular or irregular. Is it regular or irregular? If we see here, there is 1, 2, 3, 4. That's the 2 RR interval, a little bit more than 4. 1, 2, 3, together it is 4. 1, 2, 3, 4. 1, 2, 3, 4. So that means it is regular. If it is regular, we can check the heart rate. So what will be the heart rate if it is 300 divided by 4? So around 75, right? If you do a little bit mistake in here, like let's say it is 70 or 65 and you say 75, it's fine. They don't want the exact heart rate. So you've got the heart rate, we know it's a regular rhythm. Then we check at the P wave. So is the P wave present? We see that yes, P wave is there. And then we check the QRS. QRS normally should be between 1 to 3 small square. It's at least 1 small square, which is good and normal. Then we check the ST wave. And when we check the ST wave, we check whether it's in the isoelectric line. We can see that ST wave is in the isoelectric line, which means it is not a ST elevation. And then we check the T wave. T wave, what we normally look for, is it a very tall peaked T wave? Or is the T wave is inverted like this? But this one is normal T wave, so that's good. So far, we haven't got anything abnormal. When we don't get anything abnormal, we look at the QT. That's the Q, and that's the end of T. And then measure how many small square is there. So there is 5, 10, 1, 2, 3, 4, 14, 15, 16. So at least 16 small square is there. We know that normally is between 8 to 11. This patient has got 16. So definitely this is a prolonged QT. Okay? Before you finish reading the ECG, definitely check the rest of the ECG for any other changes. So then quickly check V1, is there anything abnormal? V2, V3, V4, V5, V6. Check the lead 1 and AVL. Check lead 2, 3 AVF. So you will see there is nothing wrong there. So that's how we read ECG. Okay? It might look that it's taking a long time, but if you know the step, it will not take more than 10 seconds to read this ECG. And in your mind, you also know that we know that there is a case of prolonged QT syndrome, which comes under syncope. And that's the only case where we usually get an ECG, right? So sometimes that also comes into our head. So immediately you will look at the QT, and if the QT is prolonged, then you can, at least you can be assured that yes, I've got it right. Does it make sense to everyone how we have done the ECG reading? Yep. HOCM doesn't have a ECG problem. Only thing we can get in a HOCM, that patient can have a left ventricular hypertrophy, nothing else. So you can't diagnose HOOCM on a ECG. You need an echocardiogram to diagnose that. All good. Now, so your second task or the third task in here could be explain the ECG to the examiner. So you will use the same format. So dear examiner, I would like to explain the 12-lead ECG of my patient who presented with a syncope. Her heart rate is about 75 beats per minute, regular rhythm, P wave is normal in size and shape, QRS is normal, there is no ST wave changes, T wave is normal, but the QT is prolonged in this patient. So I believe this patient has got a prolonged QT syndrome. Thank you, examiner. Okay, so that's how you're going to explain the ECG to the examiner. You come back to the patient and now you explain this to the patient. So you'll say, John or Jenny, most likely you have a condition called prolonged QT syndrome. Do you know what that means? No, doctor. Well, so in this case, there will be an ECG with you, right? So you will say, this is the electrocardiogram of your heart, which is the recording of the electrical activity of your heart. Let me draw a picture. So you can say that this is your heart. Every heartbeat starts with an electrical signals that tells your heart to squeeze and pump blood. So you can just quickly draw the heart electrical system and say every heartbeat starts with an electrical signal that tells your heart to squeeze and pump blood. After that, the heart needs a brief pause to reset before the next beat, like recharging a battery. This reset time is what we call QT interval in the ECG. Very good explanation if you can think about it. So it's a kind of like, you will say every heartbeat starts with an electrical signal that tells your heart to squeeze and pump blood. After that, heart needs a brief pause to reset before the next beat, like recharging a battery. This reset time is what we call QT interval in the ECG. In your case, this reset part of the heartbeat is taking longer than normal, which can cause the heart to beat in a dangerous, irregular way. And that can result in impaired blood pumping, causing the frequent collapse that you are getting. Sometimes this condition can run in the families. Sometimes it can be due to some medication, dehydration, salt and water imbalance, etc. It could be due to other causes as well. Then you can give some differential like before. Unfortunately, this condition can sometimes cause serious consequence. That's why I need to admit you to the hospital. I'll call for a heart specialist to come and review you. Please don't get scared. You are in safe hands. We will do our best to manage your condition. Okay? So always make sure if you say something is scary, always say, please don't get scared. You're in the best hand and we'll do everything possible to manage your condition. The specialist might want to do a few more investigations, such as some blood count, liver kidney function, blood sugar, lipid profile, and an echocardiogram, which is a heart scan. As part of the management, some lifestyle modifications are very important, so please avoid any medication which can prolong the interval. So you will not know which medication can cause that. So if anytime any doctor wants to give you a new medication, please let them know that you have this condition so that they are aware of it. Try to avoid intense emotional or physical stress. Stay well hydrated and maintain a proper salt and mineral balance. Avoid loud alarms or sudden noise because it can set off your heart. Specialists might also start you with a medication called beta blocker that can protect your heart from going into dangerous rhythm by slowing down its response to stress, exercise, or any stress hormone. If you continue to have the symptoms or having frequent collapse, specialists might consider a pacemaker to prevent the heart rate from going too low. In some high-risk cases, a small device called implantable cardiac defibrillator may be placed under the skin to shock the heart back to normal if needed. But this is extremely rare and most of the patient doesn't need it. Since this condition can be inherited, I will ask a genetic specialist to check if you have a gene mutation which has caused it. If we find one, we will also arrange genetic counseling to help you and your family understand it and decide if other family members should be tested too. And finish with lots of reassurance. So you can understand that usually the management doesn't come in exam, but if it does, you need to talk about it. So initially, you admit this patient, get a cardiologist to come and review the patient, do some blood test and a echocardiogram, which will be done by a specialist. And management, definitely some lifestyle modification advice is needed. Medication, usually beta blocker is the commonest medication which will be given to these people, and they normally don't need anything else. But if they get frequent collapse, sometimes pacemaker might be inserted. And very rarely, very high risk cases, ICD might need to be placed just to shock the heart to come back to normal if it is really needed, but it's not that common. And lastly, end with genetic counseling. Okay? Make sense, everyone?
Dr. Arshan, the quick question, if
Yeah.
there's no DD, still we have to give the DD in the management?
It's a good idea if you have some time. Normally, if the task is diagnosis and differential, then you have to do it. But if the task is just diagnosis, then I normally say a little bit like, I don't explain that in that case. So I'll just say it could be due to other causes, like some other heart condition, like heart attack, could be other rhythm related problem, but you don't have any of them. So then I don't explain a lot. I just give some differential name and be done with it. Okay.
Yeah, because of the time constraint is left.
Yeah, because you will not have time. If in this case you need to talk about management as well, you will not be able to make it in time.
Okay, yeah, thank you.
Thank you. All good, everyone? All right. Next case, postural hypotension. Very, very important. So got one case, a middle-aged woman comes with dizziness for the last several days. So sometimes postural hypertension doesn't come with complete loss of consciousness. Sometimes it can be just dizziness. Sometimes they can come with a fall. Like this one, a 65-year-old man comes to see you because he had a fall yesterday. So all of them are similar cluster. Syncope, dizziness, lightheadedness, having a fall, all of them, your question are same. Differential are pretty much same. Okay? So use the same format for any of them. So in this case, the history is a little bit different. So have a look. So hemodynamic stability, like how we did. Our HOPC is not loss of consciousness, rather it's dizziness. So we will say in this way, we will not do pre-syncope, syncope, post-syncope for dizziness case. We'll just finish it with one detailed question. Can you tell me a little bit more about this dizziness? Patient will give some idea. We need to know, do you feel lightheaded and giddy? Or is the room spinning around you? Why we are asking this question, guys? Why it is that important?
For the vertigo.
Yes, very good. Because we need to know what this case all about. It could be a vertigo case entirely different, right? So that's the first thing we need to know, that whether it is a case of dizziness, where patient will feel lightheaded and giddy, If the patient say, no, I feel like my room is spinning around me, that's a different case fully, which will not be this case or this cluster. So that's why we ask this and make sure we know what case it is. Then we ask, when did it start? How many episodes so far? Can you explain a few of the recent episodes? So if patients say I had multiple episodes, I will ask that, can you tell me a few of the recent episodes? What were you doing? How did it start? How long it persisted? Give me a little bit more detail. Did you fall or lose consciousness at any time? If the patient lose consciousness, then we can ask those pre-syncope, syncope, and post-syncope question. But if the patient did not lose consciousness, we don't need to ask that anymore. Okay? Once we have done this, then we go to the differential. So for CNS, in here we will ask all the CNS related question. So first of all, for TIA or stroke, any headache, any blurring of vision, any weakness, any part of the body, any difficulty with your speech or swallowing. For epilepsy, jerking movement like seizure or convulsion. If we have time, we can also ask that any tongue bite, did you lose your... It's really not needed because one question is enough. So any jerking movement, any head injury, fever, nausea, vomiting, neck stiffness for meningitis, and for brain tumor, because brain tumor also can come with dizziness, any early morning headache, any difficulty with keeping balance. Okay, so that's all of our CNS related differential diagnosis. For serious, same question, any chest pain, shortness of breath, racing of your heart, any swelling of your foot or ankle. Why we're asking this? CCF. CCF patient can have dizziness. So heart failure patient. So that's why we're asking. If we have time, we can ask all other question of CCF, but we don't have that much time. Hypoglycemia. So does it happen mainly when you skip your meal? Any history of diabetes or high blood sugar? Vasovagal, does it happen when you stand or sit for a long time or do heavy exertional activities, mainly in hot, sunny weather? Very good question for vasovagal, so you can use that. For postural hypotension, now we are coming into our case. Do you feel dizzy when you change your position, like standing from a sitting or lying position? Patient will say yes. Then you try to find out that why this patient having postural hypotension. There has to be some cause. Any recent vomiting or diarrhea? Vomiting or diarrhea will cause hypovolemia, which can cause postural drop. Any fever, flu-like illness, same any infection can cause it, especially sepsis. Any dizziness after eating. Any increased frequency or urgency of urination. Any shaky hands or difficulty with walking. Any loss of memories. Is it worse first thing in the morning? Now, why we're asking all this, I will discuss it just in a bit. So we just ask all this question, any dizziness after eating, any increased frequency or urgency of urination. There is a case in exam where patient had UTI. And when you ask about how's your bowel habit and how's your water works, patient will say, I'm getting to the toilet a lot these days, or I'm having a lot of I need to get up multiple times at night, so nocturia. So sometimes a tiny little detail in exam can give you the case. So that's why in this case, definitely ask about how is your water works, any burning sensation during passing urine, or any burning or stinging sensation, any increased frequency or urgency of urination, any loss of memories, especially any shaky hands or difficulty with walking. So we get resting tremor in Parkinson gait. So that's why we're asking all this question. Wait a little bit, that there is a reason why we ask that, why, like in the morning, loss of memories. We'll come into that. After we have asked the postural hypotension question, then we go into the others. Anemia, so same question. Stress, past medical, same question. Very important not to forget about this past medical. Ask specifically any history of diabetes, high blood pressure, any heart condition. Ask about smoking, alcohol, and any medication. Medication is history should be in detail in here because most of the time it is polypharmacy is the cause of postural drop. So if patient say that, yes, I'm on few medication, ask what are the medications you are taking, and you might find out patient is on ACE inhibitor, patient is on diuretics, patient might be on a alpha blocker like tamsulosin because patient has BPH, benign prostatic enlargement. Then you ask that, is there any medication which has been recently started? Any recent increase of dose of any of the medication? Okay. Who takes care of your medication? Any chance of double dose? Okay. Very important because you will end up finding few things here that either a new ACE inhibitor was started recently or a diuretic was added or dose was increased. So something will be there in this case. And lastly, finish with any family history of sudden cardiac death. So that's your history for dizziness. Now, before we come into the rest of the things, I want you to know what is actually this orthostatic or postural hypotension. So orthostatic hypotension is suspected. First, patient will say, when I change my position, I get dizzy. And you need to confirm it by checking the blood pressure in both positions. So if we find out that there is a gap like this, so when a patient stand from a sitting position, if their systolic blood pressure drops below 10 millimeter or their diastolic blood pressure drops at least 10 millimeter within 3 minutes of standing, that's what we will be calling as postural hypotension. Not a single one, so you need to take multiple reading, and if multiple readings showing that patient has this kind of postural drop, then we can confirm it. Like let's say someone having a blood pressure, their sitting blood pressure is 140/70. And when the patient stand, the blood pressure is 110/70. So you can see that on standing, the systolic dropped 30, which is more than 20, and that is what we will call as postural drop. When a patient has this kind of drop of blood pressure, usually there should be a reflex increase in heart rate. So normally when a patient stands and the blood pressure drops like this, heart can sense that. So heart starts pumping a bit faster so that this blood pressure can be maintained, right? That's called reflex increase in heart rate. But if this reflex is lost, so lack of reflex increase indicates some autonomic failure. So most common cause of autonomic failure is diabetic neuropathy. So that's also something that we look at, that how is the heart rate of the patient when the patient had this drop. Okay. So causes of orthostatic hypotension. Causes of orthostatic hypotension, the first one is volume depletion. So hypovolemia could be dehydration related to vomiting, diarrhea, excessive sweating, or low fluid intake. Could be related to blood loss, like patient had a surgery, trauma, or internal bleeding. That's a common cause or most common cause. Autonomic failure could be in Parkinson patient. That's why we're asking about the shaky hands, the balance issues. Diabetic neuropathy, very important to rule out. and multiple system atrophy. Now, we don't need to go into that. It's not an exam case, very rare, so please don't go into that. These two are the most important ones for autonomic failure. We will think of diabetic autonomic neuropathy only if the patient is diabetic. Diabetic neuropathy patient will have some other features like they get bloating, they get abdominal or indigestion, they get diarrhea, constipation, okay? They get sexual dysfunction. So lots of findings are there in a patient who gets diabetic autoneuropathy. Diabetic autoneuropathy, we will only think about it when we see that patient has a known diabetes and it's not well controlled. So that's the GIT symptom, bloating, heartburn, sometimes delayed emptying of the stomach. So they always feel full, okay? They also get genitourinary problem, which is sexual dysfunction. They get urinary retention, so they have some trouble to urinate. So erectile dysfunction is common. They also can get sometimes excessive sweating is one of the feature in this patient. So mainly look for the indigestion, bloating, the diarrhea, constipation, sexual dysfunction, urinary retention. Ask few of these questions to rule out autonomic neuropathy if it is a diabetic patient. And then we have got all the medications. So antihypertensive is the common one. So ACE inhibitor, beta blocker, sometimes vasodilator, even antidepressant, alpha blocker, diuretics. These are the commonest medication which can cause this. Prolonged bed rest. So someone who has like long-term chronic disease and they're deconditioned, like a stroke patient, prolonged bed rest can also cause this kind of postural drop if they suddenly change their position. Cardiac causes heart failure, as we already discussed, and also sometimes any arrhythmia, either bradyarrhythmia or tachyarrhythmia can cause the same thing. Endocrine causes, so Addison's disease, diabetes, hypothyroidism can be a cause. Sometimes it could be just senile, like age related, because as the patient gets older, the vascular tone in the elderly is no longer there, so their blood vessels becomes a bit slack, so it can't push the blood into the brain as hard as younger patient can. So when they stand, because their vessel is not that much strong, they don't usually get their blood pressure does not usually get their blood pressure usually drops because they get peripheral pooling of blood. Okay. So that's all are the main causes of postural hypertension, which most of the things we have already asked in our history. Volume depletion we asked about the autonomic medications, we are asking about the heart failure, arrhythmia. So almost everything we asked. So when we do do these kind of cases, we always make sure we rule out any drugs that can cause the postural drop. We rule out any acute causes, and we also rule out if there is any autonomic failure. So autonomic failure will only be diagnosed if patient has no reflex rise of heart rate after standing. Okay, so that's one of the thing. Find out if there is nocturnal supine hypertension. So that's one of the thing that we might find out in this patient, that when they lie down and when they sleep, their blood pressure goes high in patient who has autonomic failure. So it's not that important to go into that detail in exam, but that's something that we should know, that in an autonomic failure patient, their blood pressure can get high in supine, especially when they're sleeping. So in a normal person who have intact sympathetic activity, okay? So in a normal patient during sleep, their sympathetic nervous system slows down every time, like because we are not scared about anything. We are not having the fight and flight hormone when we sleep. So during sleep, our fight and flight hormone slows down, which eventually causes vasodilation. So blood vessels get dilated and blood pressure drops. Okay, that means our sympathetic system is intact. But if someone's sympathetic system is failed, then even though they are sleeping, still during night their blood pressure remains high. So that sometimes can indicate that they have autonomic failure. Then we look for Parkinson, we look for diabetic autoneuropathy and those things. Does it make sense, guys?
Sir, I have a query, small question. That is, a patient presented with dizziness, and when we ask the examiner about the vitals, and he or she shows me that there is a postural drop, and then I have a clue about it is maybe a case of postural hypertension. And in that case, should we go for the details of history taking of cluster of syncope, or we only focus the important DDs or postural hypertension? But because both are little bit different, I think that.
So it will be like this. So exactly how we have done this. So because the dizziness can be due to CNS cause, dizziness can be due to CVS, could be any other thing as well. Okay, we
Okay.
can't be sure that patient only having dizziness because of postural drop. A person can have multiple causes of postural drop, and in exam
Okay.
you get multiple disease in a same patient, and you can't
Okay.
miss the multiple one as well.
Then it is
So
said to exclude all of the DDs.
yes. So
Okay.
at least all the important ones, so CNS, CVS, vasovagal, those things definitely needs to be ruled out. But you will need to also find out the cause of postural hypertension. So is it hypovolemia? Is it something related to autonomic failure? So those things we will definitely need to find out from the history as well.
Okay, sir. Thank you.
What about the significance of dizziness after eating?
So dizziness after eating is not that important, but it is a indicator that patient might have postprandial hypotension. What happens that if a patient feels dizzy after eating, sometimes we can think that this patient might have got push usually postprandial hypotension. So sometimes it indicates that patient might have, when they eat, their blood pressure drops, or they get reactive hypoglycemia. That means when they eat, instead of having their blood sugar going high, there is too many insulin coming up to play there and causing hypoglycemia in this patient. So it can usually happens in patient with, like, they are very elderly patient, very frail. Those patient can get these kind of features. So when we get a dizzy patient after eating, we look for whether the blood pressure is dropping, whether they are getting hypoglycemia after eating. That's the only reason.
Thank you.
No, dumping syndrome is not needed unless we know that this patient had a recent bariatric surgery or weight loss surgery. Otherwise, no need. Okay, so coming to just finish this history. So you start with the dizziness question, then ask all the necessary differential diagnosis. You will find out this patient gets dizzy when they change their position. Try to rule out as many causes as you can, find out the cause. So vomiting, diarrhea, fever, dizziness after eating, because there is an exam case about this urine related problem. Ask about urine, ask about Parkinson. Now, also ask about other differential diagnosis. Okay. Now, positive point in this case is patient said that he felt dizzy when standing from a sitting or lying position. So we got this is a case of postural hypotension. Patient also said patient is diabetic for many years, but well controlled. These are the medications. So we can see he has diuretic and ACE inhibitor. Also history of heartburn, loose stool for a while. In the physical exam, we only got postural drop, nothing much. So the first case that we have got can be multiple things. So we have got a patient who has got medication, can be a cause. This patient can have diabetic autoneuropathy given heartburn, loose stool. But if the diabetes is well controlled, then we will not think about it as our first cause. Okay, so see how we're explaining it. Most likely you have a condition called orthostatic hypotension or postural hypotension. This occurs when your blood pressure drops when you stand up too quickly from a sitting or lying down position. As a result, you may feel dizzy, lightheaded, or even faint for a short time. Now, if your time permits, you can explain it. So when you stand up, gravity pulls blood down to your legs. Normally, your body quickly adjusts by tightening your blood vessels and increasing your heartbeat to keep the blood flowing to your brain. But if your body does not adjust fast enough, your brain gets less blood for a moment, causing these dizzy feelings. So that's the way, right? So when we stand up, gravity will pull up the blood to our legs. But normally our body can adjust to this by doing the vasoconstriction. So tightening the blood vessels so that blood can push to the brain. But in patients who has this postural drop, their body cannot adjust fast enough. Okay, and that's why their brain doesn't get enough blood supply for that moment, causing this dizzy feeling. Could be due to many reasons, especially if you are dehydrated or not taking enough water, or you are having severe vomiting, diarrhea. Could be due to infection, strenuous exercise, but in your case, most likely it is due to the multiple blood pressure lowering medication you have been taking. So in here, you will need to say that you're taking this ramipril, which is a blood pressure lowering medication. You're also taking furosemide, which is a diuretic, where you lose more fluid through your urine. Both of these medication can reduce your blood volume significantly. And that's most likely why you are having this. Also, you are diabetic. Sometimes it can cause some nerve damage where the system that helps to push the blood to your brain does not work properly, called autonomic failure. Okay, uncontrolled diabetes usually causes this, where patient can have heartburn, bloating, diarrhea, constipation, difficulty with urination, sexual dysfunction, and also they have this similar dizziness with change of position. But as your blood pressure is well controlled, it is less likely. It can also happen in Parkinson patient, but you do not have any symptoms related to that. This type of dizziness could be due to other causes. Then you can give some differential diagnosis, like it could be heart rhythm disturbance, a structural defect, heart attack. Sometimes it could be a stroke, seizure, head injury, salt and water imbalance. But in your case, these are all very unlikely. As part of the management, I would like to do some basic investigation to check your blood count, any inflammation, liver kidney function, blood sugar, thyroid, and the ECG. Also, to rule out autonomic failure or nerve damage, I would like to do a 24-hour blood pressure monitor to check your blood pressure at night. Remember, we say that if this patient has autonomic failure, then at night the blood pressure will remain elevated, like it will not drop. If all the investigations come out normal, then we can be sure that it is the medication only. In that case, I will reduce the dose of the medication or change the medication accordingly. Also, it is important to follow some general measure to reduce the dizziness. So you can say like few of these things. Do not stand quickly. Stand up slowly, especially when you are especially after lying down or sitting for a long time. Try not to tense your leg muscle or cross your leg when sitting, which will help push the blood to your heart. Avoid alcohol, especially in the morning. Drink more fluid in the morning and throughout the first half of the day. Join a exercise program which can improve your circulation, and you can follow this half-minute rule. So when you get up in the morning, sit up slowly and stay for 30 seconds. Put the legs over the side of the bed for 30 seconds, and then slowly get up and walk. Okay? And finish with 4R. So you will see that we say 4R. What is this 4R that we use at the end? 4R means review. So if you need to review this patient, so because you are sending the patient for some blood tests, so you will review the patient after the blood test is back. So I'm going to review you after the tests are back. Referral. Are you going to send the patient to some specialist? If not, then don't need to mention. What is the red flag that will lead the patient to come to you immediately or go to hospital? And always offer some reading material about the diagnosis. So in this case, you will say, I would like to review you after all the blood tests are back. I'll give you some reading material about it. But anytime, if you feel that in between that, you're having more frequent call-ups, you're losing consciousness, you're having weakness in your one side of the body, or you're having difficulty with vision or speech, you're getting chest pain, shortness of breath, please go to the hospital immediately. Okay, so red flag is that what is in this patient, what's really important that can be a bit different or can be very serious, like a stroke or heart attack. So if those kind of symptoms happen, patient need to go to hospital. Clear, everyone?
I just wanted to ask like about the measurement of blood pressure. When we say like for postural hypertension, the guideline says supine. So is it going to be sitting or lying down?
So supine is okay, but for diagnosis of postural hypertension, you'll be doing as sitting position, and then you ask the patient to stand, and within 3 minutes of standing, you will check the blood pressure. So sitting and standing will be fine for diagnosis.
Thank you. Thank you.
Thank you. All right. So any questions, guys? So this is a tricky case because finding out the cause of the postural drop is important. And you will not find this kind of explanation anywhere because the explanation that we are doing, we are taking things from therapeutic guideline, and usually in any other notes, they don't go that much deeper. But if we get a postural hypotension patient, it's not always just a medication cause. There might be a lot of other things. So always know that sometimes it's not always just a multi or polypharmacy causing this. It can be a lot of other things which we should know. There is a case of bradycardia in exam causing postural hypertension. Okay, so keep an eye. Make sure that you know the basic. Make sure you know why you're asking all of these questions. Okay. Now, is there a medication for orthostatic hypotension? Yes. If like let's say that you have done everything, patient followed all the general measures and all, but is still patient having significant symptomatic orthostatic hypotension, there is a medication called fludrocortisone, which is a synthetic mineralocorticoid that can be given in this patient. There is another medication called midrodin, which is a short-acting vasopressor, can be given as well, but commonly we give fludrocortisone in patient who has significant orthostatic hypotension. All right?
Yes, doc. The junior doctor can start on this mineralocorticoid, or
No.
we have to. No. Yeah.
No, you can't. It has to be a specialist.
Okay. Thank you.
So you only send the patient to emergency department if you find something really serious, like patient has a heart block causing the syncope or dizziness, complete heart block, right? Or patient has got possible TIA or stroke, possible cardiovascular condition. So it depends. If it is just orthostatic hypotension because of polypharmacy, we are not going to send the patient to emergency. Okay, vasovagal syncope, 18-year-old girl fainted during marathon running during annual sports. Now fully recovered, mother came to consult with you. So 18-year-old, if mother is talking to you, you still need to ask that whether, so in this case, what happens that if it is the 18-year-old and mother is here, so you are talking to the mother, not to the girl, because there will be only one role player. But 18-year-old should be able to talk about their own condition. If mother is here, you need to ask the mother that, so you can say, hi, Jenny, I'm Dr. Arshan, very nice to meet you. I see your daughter had a fainting during her marathon. It must be very stressful for her. How is she doing now? You will make sure patient is vitally stable, and you'll ask the mother, Jenny, I understand you are very concerned about your daughter, but because your daughter is 18, I would like to know that if you have got the consent from your daughter to talk about her medical condition. So we always ask that, have you got the consent from your daughter to talk about her condition? If the mom say yes, then we can talk, because we can't be sure whether they are lying or not. It's not our job, but medical legally, if we can ask the mom that, have you got the consent? If mom say yes, it's up to her if she is lying. Okay? So that's for everyone. So you can't talk to anyone except your patient about their medical condition. That's for clinical exam as well. So ethics is really important. So make sure that you know about this normal common ethical dilemma. So you always need to take permission if someone is talking on behalf of the patient. The positive points in the history for this case was the girl was running marathon. It's a hot sunny day, and she fainted. You would find out that she was having a bit dizzy or lightheadedness before she fainted, and she skipped her breakfast before marathon, and you found that her blood sugar is 3.6 millimole per liter. So less than 4 is hypoglycemia. So this patient is having hypoglycemia. She skipped her breakfast, that makes sense. And also she had a vasovagal. So sometimes you can get multiple differential diagnoses. Sometimes in the same patient, if you ask about her period history, because it's a reproductive age group patient, you have to ask the period, feel pregnancy and all. You might find out she's having menorrhagia as well. So if a patient has menorrhagia, that means heavy bleeding during period, that can be cause of iron deficiency anemia. An anemic patient, if they do this kind of stressful or strenuous running, they will have some fainting or vasovagal, right? So all can be interconnected. So try to find out multiple things in this kind of cases, because it might not be just a single thing in the exam. So explanation in here would be, so the temporary loss of consciousness that we are just talking to the patient, like the daughter now, okay? The temporary loss of consciousness that you had today is what we call syncope. There are many reasons for it, but in your case, there are likely to be two possibilities. One is vasovagal syncope. In this condition, in response to certain triggers, such as overexerting in hot sunny weather, can stimulate a nerve in your body, causing pooling of blood in your legs. So that's the vagal nerve. As a result of that, the heart does not get enough blood, so it cannot pump blood to your brain, causing this sudden loss of consciousness. Very easy. So in response to certain trigger like excessive exercise, overexertion, vagus nerve can stimulate. Vagus nerve causes vasodilation, so there will be peripheral pooling of blood. And that's why the blood will not go to the heart. Heart will not send the blood to the brain, causing the loss of consciousness. Please do not stress. It is a very common cause of fainting, especially with your situation. And I can assure you there is nothing wrong with your heart or brain. Another condition that can precipitate this attack is hypoglycemia or low blood sugar. As you skipped your breakfast and then you had to run the marathon, that has caused low blood sugar, because when we measured your blood sugar, we also found it is quite low. So I'm going to give you some jelly beans, or I can give you some sugar drinks to make sure that your blood sugar goes up. It could be due to other causes as well, so give some differential diagnosis and say why those are unlikely. Okay, there is no management for these kind of things. They usually give you diagnosis and differential as your task. Clear, guys?
Dr. Arshan, in this case, if the only mother is coming and she mentioned that she has a consent, still we have to take a full history of everything, pregnancy, periods from the mother, right?
Yeah, everything from the mother.
Yes. Yeah, thank you.
Thank you. All right. I believe this is your last case, the recurrent
Hello,
fall.
doctor.
Yeah.
Hello, doctor. I have a question. When a kid older than which age shall we ask for the consent from the parents?
So anyone above 18, they are adult. So any adult, if you need to talk, if someone comes here to talk about them, you will need to ask consent.
Yeah, but if a kid is about 16-year-old or 15 years old, shall we still ask for that question? Is that due to the age is older than 14, due to the Australian law? I
Yeah.
don't quite. 14 is the line. Is that right?
14 is the mature minor. So mature minor, if they come to you alone without their parents, you can continue taking the history, but there are some specific thing that is covered, like like anything sexual related, like they're worried about STI, they're worried that they might be pregnant, or they want to have a oral contraceptive pill. So some you can just talk to the mature minor if they have the GILIC competence. But any others, like let's say that a 14-year-old coming to you because she wants to talk about Gardasil vaccine. Okay, you can talk to her about the vaccine, but you can't give that vaccine to her without the parents' consent.
Oh, okay, I see. Thank you.
Okay.
Okay.
Yes, Dr. Arshan. So, in your experience, they do give that kind of a tricky question in the exam, major, minor?
Only one. So there is a oral contraceptive pill case, which is like 14-year-old comes to you for OCP. So that's the only case that comes.
And it will coming in your teaching session that,
Yeah, we
major,
will discuss
minor.
that. Yeah,
Okay.
we'll discuss that in gynae class.
Okay, thank you. Yeah.
All right. So moving on to a recurrent fall case. Recurrent fall is kind of similar like all that we are discussing, but we add few more things on it. Recurrent fall comes in exam a lot. So the most common cause of recurrent fall is the elderly patient having polypharmacy, postural hypertension, vasovagal, CNS, CVS as before, endocrine and electrolyte, that's what we add here. So hypoglycemia or any diabetic complication. Diabetic retinopathy, patient can't see properly. So when they can't see properly, so they can end up falling multiple times. They can trip, they can injure themselves. So that's one cause. Peripheral neuropathy because of diabetes. So again, peripheral neuropathy patient will have numbness. So sometimes they can't feel where they're stepping. So that also can be a cause of fall. So either it's a hypoglycemia or hyperglycemia causing some complication. Electrolyte abnormality, so hyponatremia caused by vomiting diarrhea can be a cause of fall. Anemia, sometimes home situation. We ask home situation to everyone who has a recurrent fall. Why? Because let's say someone lives alone, like elderly patient lives alone, and there is poor lighting. So at night there is poor lighting, so they can easily fall. They have loose carpets, right? Or they don't have any handrail on their stair. They don't have a rail on in their bathroom. So these are some of the things which sometimes can lead to fall, and we can prevent fall by even fixing this up. So mechanical causes are always there. So we need to find that out. If someone have poor vision, poor hearing, that can be a cause as well. And elderly patient having multiple severe joint osteoarthritis, that can be a cause of fall. So we add these three differential diagnoses for every fall case. That must to ask, because you can find out some things which can be easily fixed. Definitely not vision or hearing, that cannot be fixed most of the time, but you can arrange glasses, you can arrange hearing aid, which can change a lot of their problem. Okay, so try to find out all of this in this kind of elderly patient who gets a recurrent fall. So recurrent fall, as you can see, that the history will be pretty much same, because most of these differential diagnoses we have been asking in our syncope cluster. So the history will be, so first you go in, you introduce yourself, reassure the patient that you are going to take care of him, and then ask about the fall. So could you tell me a little bit more about those fall episodes? So you get a bit of an idea, then ask how many fall you had so far. Okay, when did it start for the first time? And can you tell me a little bit detail about some of the recent fall that you had? So get an idea what usually brings on this fall. And then we just ask what happens before fall, during fall, and after fall. So it's the same pre-syncope, syncope, post-syncope question. Same thing, just changing it, that before fall what happens, during fall what happens, and after fall. Then differential severe CNS, you already know how to ask. Postural, anemia, all of these we already know. Then we ask about the past medical condition. In this case, we ask, do you have any other medical conditions such as diabetes, any heart condition, high blood pressure, any past history of stroke? If patients say, yes, I have diabetes, we need to ask detail about diabetes. So we will say, how long you are having this? Is it well controlled? Okay, or you can say, how is your blood sugar? Are you regular with your specialist? Any medication that you're taking? If patients say yes, ask the detail. What medication you are taking? Any problem with your vision? Any numbness, tingling sensation on your feet? So if diabetes positive, we usually ask a lot of details. So how long you're diabetic? How is your blood sugar looks like? If you can, you can ask, do you do regular blood test to check your blood sugar? If patients say yes, when was your last blood test? How was your HbA1c? Some patients who are good, who knows about their condition, they will say that I know my HbA1c. Some don't know it, so if they don't know it, then don't bother. Then ask, are you regular with your specialist? Are you on any medication? What medication you are taking? Are you regularly taking them? Any recent change in your medication? And lastly, try to rule out retinopathy by asking any problem with your vision, and neuropathy by asking numbness, tingling on your feet. Don't forget about medication history, because it can be positive as well. And then ask about how is your home situation? Who do you live with? Do you have enough support? So social history is always important. Any loose carpets, any problem with lighting? Do you have stairs at your home? Do they have handrails? Do you have any joint issues? Any problem with walking or keeping balance? Do you smoke or drink alcohol? Okay, so that will be our history for recurrent fall. Just like what we have done, we just added the diabetic history in detail, and we added this home situation and joint problem. Apart from that, it is exactly the same. Okay. In physical examination, because this case is quite frequently it comes in exam, so we just added few things here, especially if it is a diabetic patient. You will ask general appearance, vitals and BMI. We also ask the eye. So you will say, I would like to check the eye in this patient. I would like to know the visual acuity, visual field, and is there any fundoscopy available to rule out diabetic retinopathy? So if this case is diabetic retinopathy case, they will say yes, the fundoscopy shows diabetic retinopathy. Then do a cardiovascular exam. So it will be a quick cardiovascular. So quick cardiovascular exam is apart from S1, S2, is there any added sound like murmur? That's the only one question that we will ask. Then I would like to do complete central nervous system exam, including upper limb and lower limb neurological exam, and also other cranial nerve. If examiner said no, everything is normal, then you can directly ask, I would like to know if there is any sign of peripheral neuropathy in this patient. So what we will say, I would like to do complete upper limb and lower limb central neurological exam, including all other cranial nerves. If examiner does not mention about peripheral neuropathy, then you directly ask that, is there any sign of peripheral neuropathy in this patient? Because we know that it's important to rule out. I would like to also check the joint. So if patient mentioned that, yes, I have got knee pain or ankle pain, then only you will ask it. You will say, I would like to also check the knee joint for any joint swelling or tenderness or any restricted movement. So any joint swelling, tenderness, any restricted movement. Only if we find it positive, otherwise no need. An office test, very important, is blood sugar level, because in this case you will find out blood sugar may be 20. And urine dipstick, why? One, the fall case also sometimes can be related to UTI. So we always ask urine dipstick for any sign of UTI, like any nitrite or any leukocyte. And also we can ask about any ketone, right? Because that will suggest if patient is having dehydration because of high blood sugar. So that will be our physical examination from examiner for this patient. So the positive point in this case, patient had 3 episodes of fall so far. He has been diabetic for the last 10 years, numbness, tingling positive, and vision problem positive. Has knee joint pain, past history of a stroke, taking physio now. In physical examination, we found fundoscopic retinopathy feature and peripheral neuropathy feature and blood sugar 16. So what we have known from here, that this is a patient who has been having frequent fall because of diabetic complication. There are cases of polypharmacy related postural hypotension causing recurrent fall. So there are multiple cases that comes under this, but this is one of them. So you'll say most likely the cause of your recurrent fall is uncontrolled blood sugar causing peripheral neuropathy. In this condition, the nerve that supply our extremities get affected, causing numbness and tingling. And that's why you may not feel where you have been stepping, and that can cause the frequent fall. Also, we found some eye changes related to diabetes, which is affecting your vision, called diabetic retinopathy. And that might be also causing frequent fall in your case. Other than that, you also have knee joint changes, which can cause recurrent fall as well. See that any positive finding we get, we will need to bring that into our explanation. It's not always just a single diagnosis. Clear, everyone? So this case is about recurrent fall, and we just discussed recurrent fall due to diabetic complication. As I was saying, there was a case of postural hypotension due to UTI. I just added this explanation so that you can explain that nice and easy in exam. So if postural hypotension due to UTI, definitely you'll explain that the diagnosis is postural hypertension, explain postural hypertension as before, and then you will say, in your case, most likely it is due to urinary tract infection, as you have fever, burning sensation during urination, and increased urination for the last few days. This can reduce the amount of fluid in your body, making it harder for your heart to pump enough blood to your brain, especially when you suddenly stand up at night. In addition, during infection, your blood vessels get wider, causing blood to pool in your legs and further reduction of blood flow to your brain. So that's how UTI causes postural drop. One, that patient goes to the toilet a lot, so increased frequency of urine, that can cause reduction of blood volume. And when they suddenly stand up at night, the blood pressure can drop. Why at night? Because they're getting up multiple times at night. And during infection, there will be vasodilation, which can also cause the same thing. Please do not stress, as we can treat this infection with an antibiotic such as trimethoprim for 7 days, and you should start to feel better within few days. The treatment is usually not the case in here. It's all about getting the diagnosis. Okay? Nowadays, we start patient with nitrofurantoin. That's our first line for UTI. But if you add any of them, trimethoprim, nitrofurantoin, or cefalexin, any of those three medication will be the right initial medication for UTI. So that's all for today. That's all under syncope cluster. And today you got a bit more understanding that using a single format, we discussed so many cases. We did not need to learn the history. We did not need to learn the physical examination. All we needed to know how to come to the diagnosis and how to explain it properly. Still, that is quite difficult, right? Think that if you needed to remember all of them, if you need to memorize all these cases differently, how hard it can be. So that's what I normally do during the theory. I try to bring everything into the same cluster and make sure that your preparation can be nice and easy, and it is a smart preparation. It's not just memorizing things and then at the end of the day can't remember what I need to ask. So the classes that we take, we make sure that those are updated according to the guideline, according to the therapeutic guidelines that we follow as a doctor here. And you don't need to worry about that whether these are updated or not, because I make sure that all the things that I show to you or any other mentor show to you, they are fully updated according to the recent guidelines. Okay. There is no good mnemonic to remember all the differential, because it's a lot of differential, right? So it's not possible to remember or memorize all of this or use a mnemonic to remember all of them. Okay, but it's not very difficult to remember them. As you start doing role play, you will find out that it comes into your mind. Okay. Now, any of you have any questions regarding our course, please feel free to ask. I'm more than happy to answer. But if you want to know a little bit more, you can also go into our website, which is firstaidamc.com.au. And if you go there and go to this extensive clinical course, you will get to learn everything about the course. As I mentioned a few other times, that course has everything that anyone needs to pass the exam. All you need to do is to follow what we are doing and doing a lot of role play with your study partners. If you can do that, there is no way you will fail this exam. Now, course is divided into multiple subdivisions. So I will mainly follow this theory-based cluster-wise approach throughout the course and finish all the basic theory knowledge that you need to pass this exam. With your theory knowledge, most of the things you will be fine in exam, but still we try to cover any recent questions that is important for your exam. So in your course, we'll be mainly focusing on 2026 and 2025. Those will be our main focus of questions that we will be discussing, and we'll be doing role play. But you also get around 300 cases that we have done in the last 3 years with our previous student. All those video recordings and the notes will be given to you when you make the full payment. We also have physical examination 1 month class, which is entirely just for physical exam. And there are some added fee if you want to do our 3-day symposium, which we run as a face-to-face workshop throughout different states in Australia. We haven't got any specific time or date for this year yet, but it will be given soon because I was quite busy with this free session. Now that it is almost over, we should be able to give you some date just in few weeks. And the others, we give you recordings for every class, which will last throughout the course and also even after finishing the course. Then also you get some discussion about job hunting. You get CPD from our course. So it's everything that anyone need to pass this exam. I always advise you that when you are going to join a course, especially for something like this big, because this is the last step of your journey to become a doctor in Australia, please make sure you learn about the course in detail. Do the 2-week session, ask them to give you free session. Do not just listen to others, because there are lots of wrong people try to misguide you, lots of wrong informations. But if you feel that no, you are enjoying the classes that we are giving you, that's exactly going to be the same classes in the next 5 months. So follow your gut, follow if you feel like this is the right way to go, definitely that's what you really need to pursue. Do not go and ask a lot of people. A lot of people will give a lot of feedbacks, and our course has changed throughout this last 1 year. There is an extensive change that we have made into our notes. Our portal has been fully changed. This is a new system that we have started just last year. So there has been a lot of changes that we have done to make sure we follow the standard. And I'm sure you are also observing that during this free session. So if you want to register for the course, you just need to go to this register now button, and then it will go for like a step by step. You still have one more class with us, which will be on this Wednesday, I believe. So that's the 21st of this month. And then 23rd, we'll be having your orientation class. Okay, that's for the paid students who are enrolled students for the course. We will do the orientation class, and also the full updated schedule for the course will be given to the course group. So if any of you have made payment and we haven't added you to the Facebook course group, not the official group, which is First Aid AMC Clinical, there is a different course group for our students. If we haven't added you there, please make sure to send me a message and I'll add you there. Okay. Yes, counseling, we have a counseling class as well. So having a job in Australia is not enough for getting the general registration. You need to have a general registration to continue working in here. So you can still work at the moment, but you still need to pass AMC Clinical to get a general registration. There is WBA pathway, which can be used as a bypass, but WBA you need to wait for years to get into. and also it takes a long time. So sometimes APRA will be on your neck asking that why you haven't given AMC clinical exam. So they usually you need to pass AMC clinical within 3 years of your limited registration when you start working. So if you haven't done that, then your full registration will be gone. So AMC clinical is very important because you need to have a general registration to continue working there. You will not be able to continue with just passing AMC MCQ. So the name of the course Group D is the First Aid AMC Clinical Batch 14. So if you are in the Batch 14, that's the time you will know that you have been added. All right, guys, so that's it for tonight. Hopefully we should be able to finish the cardiology in our next session. We only have 2 more clusters to go. One is palpitation and another is hypertension. Chances of getting a job after AMC 2 is very high in comparison to AMC 1. So after AMC 2, you will be in a high tier to get the job. Okay, definitely if there are, let's say, a HR looking at 2 application and one passed MCQ and one passed both, definitely someone who passed both will be the choice. Okay. All good, guys. Thank you so much for coming. And I can see like everyone who came initially, you are still here. Like I think only 1 or 2 just gone like when we finish the class. And that suggests that you guys are enjoying the class. And we're really happy with that. Okay. Thanks all. Have a good night. Take care. Any questions, Hannah? You just unmuted yourself.
Yeah, I have a small question. Like I've not registered yet. I'll do that in the coming days. So will we be able to download the notes?
No, you can't download the notes. So the
Okay.
notes will be there. It's just because there are
Yeah, I
students.
understand. Yeah,
Yeah.
people. Yeah, I understand. I know. Okay, thank you.
Thank you. Bye.
Sorry,
Yes, Amit?
I have a question. If it is okay.
Yeah, sure.
The classes or the sessions are recorded, or it will be only online or live sessions
No,
in the
these are all
course?
recorded. So all the classes are recorded and it will be in the student portal. And it's not just for 24 or 48 hours. It will stay there. If you subscribe for 10 months, it will stay there for 10 months. If you subscribe for 15 months, those videos will stay for 15 months.
Okay, thanks, Jon. Thank you so much.
Thank you. And Syra, how often we get class with you? So you get 2 class every week with me. And you get 1 or 2 class with a role play, like a role play mentor. Yes, it's a 5 months course. So there's a lot of class that I will be taking. So most of the classes are from me, but also there are 3 role play mentors who takes classes for role play and they cover like mainly the important questions. They do role play with you so that you get to understand them as well. After 5 months, so there are 2 subscription, Saira. So you can choose 10 months. So that will give you 10 months access. And then there are 15-month access as well, which you can also go for with the subscription. So there are 4 subscription options when you go into that. So choose it based on your need. Vivek, this is not a AMC 1 class. AMC 1 class is different. We already finished the free session for AMC MCQ. Yes, everything will be covered in 5 months.
Hi, doctor. If I want to finish all of the classes in 2 or 3 months, is there any
Yes.
ready recorded classes there? And I don't have to be online and fix my time with you, and I can learn it by myself previously in advance.
Yes, you can.
There is already have some recorded classes there existed.
Yes. So we
So good.
also give like the last batch that we just finished. You get entire recording of that last batch. So, but you have to
Oh,
make the full payment. Once you make the full payment, you can see all the last batch recorded class. So if anyone wants to go for exam in 2 to 3 months and they have a lot of time, then that is the way to go.
oh, that means is all of the systems has been included in the recorded class.
Yes,
Oh,
everything.
that's so good. Thank you.
Yeah. Yeah. So we also keep that option because we see a lot of candidates just come to us within, like they want to go for exam within a month or two. They just want to go through everything. Then that is the way to go.
Okay, so good. Thank you.
Thank you.
Sir, I want to ask that all the session on will be recorded. They will be provided also.
Yes. So all the sessions are recorded and it's been happening already. So the enrolled students who have already enrolled for this course, they are getting all the recorded class in their student portal. And half of our students do offline, so that means they just do the recordings. So there are candidates who can't join all the live classes, but they get the recorded session as well, and you can finish the course in that way if you need to. But we always advise to come to the live class.
Usually the live classes will be at the same time of this class right now.
Yeah, same time, 8:30 to 10:30 p.m. Sydney time.
Okay, thank you.
Thank you. And Bibek, for AMC 1, I can't discuss AMC 1 in a 2 class. Please send me a message in my inbox if you know. So if you go to First Aid AMC MCQ, then you can find me and you can send a message. Then I can send all the information to you. So recordings of every live class usually will be available within 24 to 48 hours after the class. Like my one, I usually upload it just after class. But sometimes the role players, like the main other role players, they need a bit time. So most of the time it will be 24 hours. These are big files, and usually we finish the class at night. So sometimes it doesn't become possible to upload it before we sleep. So most of the time it happens next day. And Usha, if you haven't been enrolled, can you please send me an inbox in my messenger? We will add you. Okay. Any other questions? All right, everyone. Have a good night. Let's finish it here. Take care. Bye.